Professor Ziaul Haq, ladies and gentlemen. I'm very honored and grateful for the opportunity of sharing some thoughts with you at this excellent conference on non-communicable diseases, and particularly focusing on a relatively neglected area of what do we know about NCDs amongst children and adolescents globally. What I'd like to do over the next 20 minutes or so is to take you through a number of areas, the principal 5 components of those being what do we know about the global burden of NCDs, and particularly some emerging evidence from Pakistan. What are the equity considerations, particularly when you look at non-communicable diseases in the context of how does it impact the poorest of the poor? What do we know about risk factors and some data on nutrition transition in Pakistan in relation to children and adolescents? What has happened in recent years, particularly with COVID-19 and its impact on NCDs, particularly among school-age children. And finally, with some thoughts on what do we know about interventions by risk periods and emerging evidence on what can we do about school-age children. So the first point that I'd like to drive home is that the burden of non-communicable diseases amongst children isn't small, and it's been largely ignored in the global literature until we began to recognize its importance in the context of the recent pandemic. If you look at the top 5 causes of healthy life years lost due to disability in either boys or girls between 5 to 19 years of age, the available current data indicates that of the various risk factors, a significant portion are related to issues that are not infectious diseases. You look at the burden related to iron deficiency anemia in young children, in adolescent girls, and also mental disorders. They become quite manifest as you look at this within this age group. As a cause of mortality, there is also emerging data from several countries. And in this particular study by Shahza Fadil here from Toronto, she looked at causes of deaths among school-age children and adolescents between 2005 and 16 in a number of countries based on nationally representative data. And the important thing to highlight was that in countries that were making the transition, particularly in Latin America, Mexico, Brazil, China, you see a reasonably large preponderance of NCDs as a cause of mortality. However, she also underscored in data from India that there was still a substantial burden of communicable diseases that were killing children. And these included infectious disorders such as malaria, meningitis, pneumonia, and even childhood diarrhea. We now have data from Pakistan based on a large nationally representative cause of death analysis that we've done through a verbal autopsy survey across the country. And these data amongst young adolescents point out to a similar preponderance of infectious diseases accounting for about a third of all causes. But you also begin to see in both boys and girls a very significant proportion of deaths due to accidents and injuries. And I'd like you to have a look at how this contributes to the burden amongst boys. And as you go towards the older adolescent group, 15 to 19, this proportion of accidents and injuries, including self-harm, also increases. In addition to other non-communicable diseases that you see highlighted here. And also importantly, in the age group of 15 to 19, you have causes of death that are related to maternal factors, childbirth. And this is also because of the fairly significant proportion of young girls who get married under 18 years of age. This burden of NCDs globally and also in many low and middle income countries isn't equitably distributed. And this was a major focus of our Lancet Commission on non-communicable diseases amongst the poorest billions, a so-called NCDI that we published a few years ago. And here, if you look conceptually as to which non-communicable diseases were we focused on, we were focusing largely on those disorders that are preponderant amongst the poorest of the poor, the poorest billion. And some of these included conditions that were legacy Millennium Development Goal conditions and nutritional transition conditions, and others were more relevant to disorders that had been hitherto ignored. So if you look at this data, particularly for children 0 to 5 and also 5 to 14, many of these disorders that kill children, the NCDs, are those that are related to largely preventable disorders or things for which there ought to be health system interventions that can make a difference. And many of these are related to risk factors that have previously not been recognized as effectively as we should have. Some of those adverse risk factors relate to early nutrition and nurturing care through neglected NCDs for which health systems are neither geared up for performance. And as you very well know, many of these are very impoverishing conditions. Sickle cell anemia, the cost of care for many children with sickle disorders in parts of the world where this is predominant is massive. And we all recognize what happens to children if they have a congenital heart disease that requires surgical treatment. So some of these are things for which, as I'm sure you will hear shortly, health systems need to be geared up to overcome many of the catastrophic costs associated with these. But the focus largely over the last several decades has been on early childhood. And then towards the end of the Millennium Development Goals, we discovered adolescence. But a large proportion of the burden of non-communicable diseases is ignored in the so-called missing middle. And this missing middle of school-age children is where we are beginning to appreciate a large proportion of NCDs being clustered. The other important inequitable issue, in contrast to many other global disorders, is lack of funding, particularly in developmental assistance for health. And if you look at how much money has been available for infectious disorders or for maternal and child health conditions for children under 5, NCDs are a very poor comparison. There's been virtually no money for NCDs in the systems until very recently. And even now, across the whole range of NCDs, the money is largely beginning to emerge for mental health disorders and relatively less for prevention of conditions such as overweight, obesity, and metabolic disorders. And many disorders, including diabetes, are in the global scenario of how you can support NCDs in low and middle income countries, virtually non-existent in public health programs. The other issue to consider, the third point that I wanted to talk about, is of overlapping risks or non-communicable diseases in populations, particularly of school-age children and adolescents. And there are a number of these conditions that we are beginning to appreciate. Some of these are related to issues like climate change, and others are related to issues that we can easily prevent in our environment. And smoking is one of those that I'm not going to talk about in any great detail today, but I'm sure somebody ought to cover in terms of its risks in various populations. If you look at young children, particularly young adolescents, school-age children who are exposed to secondhand smoke at home, the prevalence in many low and middle income countries are around 20 to 30%. When you go to what happens to secondhand smoke exposure outside the home, that proportion grows even greater, which calls into focus the importance of general smoking prevention or restriction legislations. You look at tobacco use amongst the youth, 13 to 15 years of age, and a large number of global surveys have pointed out this burden to be disproportionately distributed and increasing in low and middle income countries. As you can see, much of this burden appears to be in the geographic south. Now you add to some of these environmental risks the whole issue of diet, lifestyle, and nutrition patterns. It is no big surprise to us as parents that if you look at vegetable and fruit consumption, many of these geographies have very low consumption rates amongst youth and children, partly because of ignorance, but also because of the expensive nature of being able to take a balanced diet, which includes a high proportion of fruit consumption. You add physical inactivity to the lot, and you begin to recognize why we are facing a global catastrophe with rising overweight and obesity. And in this particular bubble plot that I will show again, you begin to see on the y-axis the change in mean BMI over time, and on the x-axis, how this changes according to GDP per capita income. And what you can see very clearly is that over time and with increasing wealth, the proportion of high BMI rates amongst men or boys here, a 19-year-old, is increasing significantly. And the same you see amongst girls over time in terms of this relative change, particularly in populations which have low GDP per capita income. And you see this also reflected in the exponential increase that we see amongst girls and boys of obesity over time that has continued unabated. We look at Pakistan, and there is emerging data to indicate that this is also becoming a public health issue of great importance. Our National Nutrition Survey in 2018 pointed out to very low rates of obesity in young children under 5. But that changes very rapidly when you get to adolescence. And in adolescent girls, the areas where you're beginning to see pockets of obesity emerge are not your wealthy provinces, but you're also some of your low-income provinces where the factors which are driving this increased obesity rates are to do with not just consumption, also with lifestyle and restriction on the activities of young girls. And no big surprise that by the time they get to reproductive age, you see this clustering of obesity in our population. You see this very clearly in the nutrition transition of women of reproductive age by acid quintiles. And if you compare the 2011 National Nutrition Survey data with 2018, what is very clear over here is that the growth in overweight, for example, is the greatest amongst the poorest quintiles. And that is one of the reasons why this is an important public health issue, not just for the urban population or the relatively rich, but also across the board in our rural populations as well, where there needs to be intervention, not just in nutrition and dietary factors, but also in physical activity. There is almost no information on school-age children. So we undertook a population-based survey of school-age children for their nutrition and health in 2019 and 20. And the emerging data indicate clearly that we are beginning to recognize overweight and obesity as important factors in both Punjab and Sindh, with figures close to around 7 to 8% of these children between 5 to 14 years of age. Now, what can be done? And what is the global progress in terms of NCD policies? And what has happened to this in recent times? Now, already before COVID, it was clear that the only countries that have begun to implement NCD programs and policies were those who were relatively rich, and where the transition from the MDG agenda had moved on to an agenda which was much more holistic. But if you looked at what policies had been implemented, a wide range of these policies were either poorly or incompletely implemented. And in terms of transition between 2015 and 17, there only about 7% increase overall in a range of these policies that you see highlighted here. NCD targets, risk factor surveys, smoke-free environments, and also food marketing and food environment interventions. Now, COVID-19 interrupted a lot of the global progress in this regards, and we undertook an analysis of how COVID-19 had impacted directly or indirectly the circumstances in South Asia. This was work done in collaboration with UNICEF and published in 2021. And as you know, COVID-19 hit the region, maybe in terms of mortality unequally, but in terms of how it affected the populations, all countries in the region were affected. And you can see this also in terms of the relationship with the various peaks of COVID-19 in terms of deaths per million population. Now, very early on, the entire region put a number of stringent measures in place. And you see this through this stringency index, which looks at measures early on as part of the pandemic between March, April, and June, July 2020. And a big part of these interventions at that time was also the unfortunate school closures that were not only implemented, but continued, despite the fact that there was no evidence clearly that it made a difference. So we were interested in the impact of these mitigation strategies on what had happened overall to maternal, child, and adolescent health and well-being. And this graphic shows you the wide number of direct and indirect effects that we were focused on. And I want to, for a moment, just talk a little bit about interruption in education and what happened as a consequence of school closures. Now, school closures in our region, as in many other places, were ubiquitous. They happened in most places, and they happened very rapidly. And by May, most schools were closed, and they started to reopen very slowly. And even in South Asia, you will notice that many schools remained closed well into the summer of 2021, and notably in some countries like Bangladesh, they did not reopen until very late. What was the impact of these school closures on education and other outcomes? We estimate that around 400 million school-age children had potentially dropped out of school in that early phase of the pandemic. And a large proportion could not be reached by any other mechanism of remote learning. So the impact on learning as an aspect of the school closures was enormous. This had direct consequences in terms of educational achievement and on learning, and indirectly in terms of how it might impact over time if there were no mitigation strategies on net earning potential and a potential 1.5% loss of a country's GDP if you were not able to address this. And we know that many of these children who dropped out of school would never go back to school. Now, the impact of this on young girls getting married or adolescent girls dropping out has been also excessive, and we estimate that close to around 400,000 excess adolescent pregnancies took place in the period between 2020 and 2021. Now, the one thing that we do have data on is the impact that this had on mental health of school-age children. And we've recently published this analysis in the BMJ looking at the impact of COVID-19 closures on mental health in school-age children. And if you look at the figures, there are close to around 32% increase in anxiety and about the same proportion of increase in depressive disorders. And that's one of the reasons why I think the pandemic has exposed the propensity of this age group for mental health impacts, and also the opportunities of doing more in this so-called missing middle by interventions that can make a difference. So what do we know about preventive solutions that are possible and need to begin early? We know that across the continuum of age, this age between 5 and 15 years of age is where currently very little interventions are in place in systems where you don't have systematic school health or nutrition platforms. These are also areas where you can regard this as strategies that can take advantage of many of the digital interventions available. And many of the domains of these interventions include both infectious diseases, lifestyle interventions, as well as mental health interventions, including interventions to prevent injuries. Now, we've reviewed this subject pretty thoroughly recently, published in the Lancet in this part of this Optimizing Child and Adolescent Health series, and the detailed evidence reviews have been published in Pediatrics as a full supplement and are highlighted here. Now, I don't have time to go through everything, but it's just to indicate that of the various health domains that we reviewed for school-age children and provided the evidence from low and middle-income countries, was a significant proportion of interventions that related to accident and injury prevention, and also mental health and non-communicable diseases. And I would encourage those attending this conference, if they have an opportunity, to look at all of that evidence in the context of what exists. Now, we were particularly focused on evidence from low and middle-income countries, but to do that, we had to look at the entire available data, both from primary studies as well as available reviews. And we looked at whatever evidence was available from high income as well as low income settings. And in general, it's very clear that there is relatively less evidence from low income countries, but it's not a net zero. And where their data was available, we pooled it, analyzed it, and made it available as packages for people to implement. For obesity prevention and targeting risk factors, a number of these modifiable interventions that are available, ranging from preventing tobacco use, improving diet, and also focusing on physical activity, and addressing many of those issues from a very early stage. This is very much consistent with interventions that were highlighted by the WHO Ending Childhood Obesity Commission, ECHO Commission. And this looked at both the obesogenic environments and also interventions that could be focused on 6 areas: physical activity promotion, healthy diets and improvements in the food or dietary environment, and also care that needs to start pretty early in childhood, including promotion of breastfeeding. One area that I might just summarize for you is interventions that we looked at in terms of physical activity and what healthy digital media use could use for children and adolescents. Christina O in my program looked at this in the context of the evidence available, and it's very clear that some of these interventions, if properly implemented in schools and through mass media, could reduce sedentary behavior quite significantly. And you can see this very clearly in the forest plot over here. We don't have enough evidence from the literature yet to look at what impacts could there be on moderate to vigorous physical activity, but this is so much dependent upon schools and what interventions or facilities are available in schools, and it's something to be considered as we look at our own policies. Finally, mental health and positive development interventions are things that are in everybody's radar screen. When we began this process, COVID-19 and its impact hadn't become clear. But we looked at mental health subdomains and positive development subdomains using the nursery care framework. And it's very clear that a number of these interventions that you see listed over here, including prevention of bullying, including reduction in substance abuse, safety and secure environments and responsive caregiving, are all things that are important part of the package of interventions that we need to have for school-age children. So, ladies and gentlemen, let me conclude by giving you the key messages that I can from the NCD framework for children and adolescents. First of all, the burden is considerable in low and middle income countries amongst this age group, and is increasing in both absolute and relative terms. This is particularly clustered amongst the poorest of the poor, who don't have the capacity to pay for many of these interventions, including counseling, including many interventions that are only available to the relatively rich in terms of curative services. But we do have these interventions, and the evidence now indicates that these can address major morbidities in this age group, and they include both prevention of infectious diseases to appropriate vaccination, injury prevention, care for chronic NCDs, and support for mental health interventions. I would underscore that it requires, in addition to robust health systems, social systems, and also delivery platforms to reach those in greatest need. And some of these require financial platforms, community, school, and digital platforms. We have one of the best social safety nets in this country. It is time also to target some of those conditionalities around potential interventions to address NCDs, just as the Sehat Sahulat card potentially could do in the Khyber Pakhtunkhwa province and other provinces if people could get their act together. But the most important thing that I want to leave you with is that whatever theory, whatever I can tell you in terms of the global evidence, the biggest challenge that we face is implementation. And no DCP compilations or agreements can make a difference unless they are accompanied by implementation, monitoring, evaluation, and importantly, accountability. Thank you very much for your attention, and I hope that you will have a great conference, and I wish I was there in person myself. Thank you.